Extubation. A. What airway, respiratory and cardiovascular problems may follow the removal of a tracheal tube? Airway problems include sore throat with or without hoarseness, foreign body causing obstruction. The foreign body may be teeth, throat pad, blood clot, etc. External compression of airway due to surgical site swelling or bleeding. Laryngospasm triggered by blood, secretions and airway manipulation during light anesthesia. Laryngeal edema, laryngeal trauma caused during intubation, such as due to bougie or stylet, leading to bleeding, swelling, and tears. Vocal cord paralysis due to direct trauma or pressure. Vocal cord dysfunction. Tracheomalacia, which is erosion or softening of the tracheal rings due to prolonged intubation. Retrosternal thyroid, large thymus or tumor, etc. Tracheal stenosis may occur after prolonged intubation. Respiratory problems include coughing, mucociliary dysfunction, diffusion hypoxia due to nitrous oxide, basal atelectasis causing VQ mismatch, inadequate minute ventilation due to ongoing sedation, post-obstructive pulmonary edema, bronchospasm, pulmonary aspiration, and respiratory failure due to any respiratory or airway compromise. Cardiovascular problems include catecholamine release, leading to tachycardia and hypertension. This may tip the patient over to heart failure if the patient has cardiac pathology. Risk of silent or overt myocardial infarction due to increased myocardial oxygen demand. The effect is exacerbated if there is hypoxemia due to other complications of extubation. B. List the patient and surgical factors that may contribute to a high-risk extubation. Patient factors may be divided into that due to airway, breathing, cardiovascular, neurological, GI or muscular. Airway factors include dysmorphia, musculoskeletal disease contributing to airway difficulties such as rheumatoid arthritis and ankylosis, airway pathology, for example, due to tumor, and obesity. These issues may have been detected at pre-op assessment or at intubation. Issues affecting breathing include respiratory disease including asthma, obstructive sleep apnea, COPD, recent upper respiratory tract infection, and smoking. Cardiovascular factors include ischemic heart disease and arrhythmias. Neurological factors include posterior fossa tumor, head injury, Guillain-Barré syndrome, myasthenia gravis, and multiple sclerosis. GI factors include full stomach, GI reflux, and hiatus hernia. Muscular factors include muscular dystrophy, dystrophia myotonica, etc. Surgical factors include surgical site involving airway, head and neck, thorax, posterior fossa of cranium, cervical spine, and any surgery requiring the use of double lumen endotracheal tube. Complications of surgery or double lumen tube use, such as bleeding, swelling, and infection, leads to high-risk extubation. Prolonged intubation is predictive of problems with extubation. Trendelenburg position exacerbates the development of laryngeal edema. Intraoperative issues not directly related to the airway, such as difficulty achieving adequate ventilation, hypothermia, significant blood loss, electrolyte imbalances, and fluid shifts, contribute to high-risk extubation. C. Outline the strategies used to prevent airway complications if a difficult extubation is anticipated in the operation theatre. In general, three options here include extubation immediately but taking steps to make it safer, extubation later, or not to extubate at all. Extubation in theatre. Pre-medicate with proton pump inhibitor if appropriate. Plan management for airway, breathing, and circulation. Involve colleagues with specific airway skills, such as ENT. Ensure full difficult airway kit is ready. Ensure cardiovascular, respiratory, and metabolic stability. Optimize oxygenation prior to starting extubation with ongoing full monitoring. Ensure full reversal of neuromuscular blockade. Position the patient left lateral head down or sitting up. Extubate while wide awake with signs of adequate reversal of neuromuscular blockade. Consideration of additional techniques, which may involve exchange of the endotracheal tube for supraglottic airway device when the patient is still in deep anesthesia, use of airway exchange catheter, use of nasopharyngeal or oropharyngeal airway, flexible bronchoscope through the LMA to visualize the larynx and vocal cords to check for cord paralysis and tracheomalacia, if indicated due to the type of surgery, extubation onto non-invasive ventilation or high-flow humidified oxygen, use of remifentanil to manage awake extubation. Delayed extubation if reversible contributing factors are present is another option. Transfer to ICU with a plan for delayed extubation, avoid positive fluid balance, ensure normothermia, normalize electrolytes, allow any airway swelling to settle, and consider need for steroid therapy. Surgical tracheostomy if contributing factors are not readily reversible. Take into account the nature of the surgery, whether flaps, spinal fixation, or complications from airway tumors are present. Included here are the Difficult Airway Society Extubation Guidelines, Low-Risk Algorithm, and At-Risk Algorithm for completion.